welcome to the next session of the Master Trainer Program. We are going to discuss understanding patients' expectations. So I think that's one area where a lot of time patients are not happy with us in spite of our best efforts. That means there is some deeper clarity or deeper understanding we require about this topic to make sure that if you're doing everything for the patient should feel happy and satisfied, and also that would ultimately help us also experience happiness and satisfaction, because when patients feel happy and satisfied, they not only praise you, they also recommend you a lot of patients, and then also they are kind of bringing more and more patients for you. So this is a very relevant topic to start with when you do your programs for your set of audience. So therefore I have integrated this session in the program. So Dr. Suyog, you could join, because I was under the impression that you will not be able to join. Okay, so my first question to all of you: if you were a patient, what would you expect from your treating team? Write in the chat box. If you were a patient, what would you expect from your treating team?
Madam, first of all, they should give me more importance.
Write in the chat box. Everybody's writing, so I request you also to write. That way everybody gets a chance to express their thoughts. So if you're comfortable, please write. Yeah. I can see a lot of good answers coming in. I'll wait for all of you to. So Neha, if you are there, I've asked a question. If you were a patient, what would you expect from your treating team? Everybody is writing their answers in the chat box. I request you also to share your thoughts. I can see some wonderful answers coming in. To start with, I think Mariam says compassion. Dr. Mehul says clarity. Satyapal says give right treatment. Totality, yes. Then more attention. Explanation about the details of treatment, yes. Involve me in the decision making, keep me informed, be kind and understanding. I would expect the team should inform about the findings and also about the waiting time. Okay. Provide the best possible treatment in a best possible way. Okay. Options, priority to me, honesty. Okay. Give me reassurance, clarity. Okay. Collaboration in decision making, humble in talking, procedure explanation in layman language. Wow. I can see a lot of good answers, written in the chat box. So, Neha, we were discussing about if you were a patient, what would you expect from your treating team? So that was my question to all of you. And the topic of discussion is understanding patients' expectations. Because we have realized that in spite of doing our best efforts, somehow we are not able to meet patients' expectations. And as a result, a lot of time patients are dissatisfied and they also badmouth. And, in social media also, sometimes the image of the hospital or the doctor or the hospital, generally healthcare provider is affected. So the session will focus on, can we understand their expectations and make sure that if we can maximally satisfy those needs and meet them. So that's the whole idea about. So I would like you to go through the case study I hope all of you had a chance to read the case study on page number 33 and 34.
Yes.
Okay. But I'm going to share the case study for everyone. So I would request one by one, to read one portion of the case study for everyone. So maybe each one of you can read part of it so that turn by turn everybody reads it. So who would volunteer first to read the first two paragraphs? Anybody?
I'll start now. Can I?
Give me 1 second. Let me have the.
I have it with me.
I need to show it. I need to show.
Okay.
Give me 1 second. 1 second. Yeah. Okay. So is it visible to all? Is the case study visible to all? Okay. So who was willing to read? Okay, Archana, go ahead. So first two paragraphs you will read.
Right after dinner, Abdul Rahman clutched his chest and told his wife Zeenat that he thought he had a heart attack. Zeenat wasted no time about Abdul and their 16-year-old daughter Katrina into the care and raced to a nearby hospital. Although the ER was quite busy, Abdul was placed into a room immediately and attended by Dr. Raghavan and the nurses on duty. After checking the history, the team checked his vital signs, including pulse rate, blood pressure, breathing rate, temperature, and auscultation. All the preliminary tests were normal, and Abdul noted that his chest pain had also diminished.
Okay. So will somebody like to read the next two paragraphs or three paragraphs? Okay. Yes, Bobby, go ahead, please.
After taking the history, from there, right?
Next paragraph.
The next paragraph. I'll be back in a while, Dr. Raghavan said. The nurses also left the room, going outside to take orders from Dr. Raghavan. Zeenath held Abdul's hand while he was still lying on the examination table. Katrina began to cry. Dad, this is scaring me so much. I don't know what I would do if anything happened to you. I'll be fine, Abdul replied. I'm feeling much better already. I bet they'll let me go home very soon. 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments, and left. Another hour passed, then another. I think they forgot you were here, Zenith said. They know you're fine, or the doctor would be checking on you. I'll find someone and see if they are finished with you now. I'm getting impatient, just sitting here with nothing being done and no one telling us what's going on. Zenith went to the large circular desk in the middle of the room and asked a nurse if it was all right for Abdul to leave since they had been in the room for quite some time with nothing much being done. I'll ask Dr. Raghavan, the nurse said. It may be a few minutes. He's with another patient. We might as well leave. He's feeling better and there doesn't seem to be a reason to sit around here, said Zenith.
Somebody else would like to read? Okay, Jayapriya, please go ahead. Yeah.
When the nurse saw Dr. Raghavan, she asked him, Doctor, Rahman's wife just said that they want to go as nothing is being done, so he must be fine. She thinks that they should leave. That is ridiculous, said Dr. Raghavan, almost shouting. So she's bored and wants to go home? Tell that female that this isn't about her or her comfort. It is about the patient. Tell her no, I am not releasing the patient until we have completed our monitoring and we are certain he is not at risk. Katrina had wandered outside of the exam room moments earlier and couldn't help but hear this entire conversation through the conference room door. She went back to the room and said, "Mom, it sounds like the doctor is pretty mad at you." Zenith said, "What for? You're kidding. He thinks you want dad to go home just because you are tired of sitting here and that you don't seem to care whether dad is well or not. He told a nurse that they were still monitoring him." "They are still monitoring him? How did I know? No one has spoken to us for hours. They just left us in that little room. I think I'll have a word with the doctor." Just as she spoke, Dr. Raghavan entered the room.
So is this something unusual?
It is not unusual in some hospitals. Definitely, they are very busy. Some do not communicate well.
So anybody who would have chest pain, what do you think will be their major concern or fear?
Madam, heart attack, cardiac arrest. That would be main concern.
And what is the fear if you think I have heart
Fear.
attack?
I'll
That
die.
I won't be alive. I will die.
I'll die.
Yeah.
I'll die. So you can well imagine the state of the patient and also the family members, that when they don't know, they're just assuming that it could be MI. They have come to the hospital, they have been examined by the doctor, and the treatment has begun, but there is no communication. So what do you think will be the assumption? So how will, as a patient party, anybody will, view this situation?
Yeah, when they will view this type of situation, first of
Mhm,
all, as there is a communication gap, there
mhm,
is no communication towards the patient, or that we didn't let them feel that how critical the patient is, because
mhm.
our body language say how the patient is. If we just if you leave that room after seeing the patient is in pain, still we left the room, and then automatically that thing will come to their mind that my patient is like unseen by the doctor or not giving importance to my patient. So if they are not giving importance at this phase, what will be the outcome? So automatically my outcome will be that I won't stay here. Better I will go. If I want to spend my money over here, why to be here? I will move somewhere else.
So I think Nivedita's version explains us that the patient can even consider that I am not being attended. Although, I mean, the patient was, admitted, assessed, and also I believe some orders were, given, and the nurses were, following the instructions and checking in the patient. But because there was no communication, so rest of the story was, created by the patient and patient party, and the story could be anything. Like the one version could be what Nivedita has shared with us. What could be the other version? Anybody else?
They could become anxious,
Mhm.
worried, and presuming all negative things. Usually that's what happens.
Mm,
They start imagining all the worst possible things,
mm.
and they get agitated and worried, and this in turn will further aggravate the patient's situation.
Absolutely, absolutely. So true. Yes, Archana, I think you wish to add something to it.
Yep. Like they also expect the doctor to speak to them after the examination, at least a minimum few words,
Would
or
have
whenever the nurse is coming to checking in. So they expect something to be communicated to them. What's happening? If in the few hours, if somebody would have spoken to the family or given some reassurance, the situation would have been much better, or these kind of situations would never arise again.
okay. So I want to ask another question to all of you. By the way, why don't we communicate? Why don't we, explain? Somebody else now. I want all others who have not spoken. Why do you think we don't explain? What is the hesitation?
Ma'am, Lavanya this side.
Sure.
I feel after listening to this case study,
Mm-hmm.
uh, and often I've experienced it also. It's maybe because the nurses do not have the clarity.
Mm-hmm.
उनको भी पता था कि मिस्टर अब्दुल जो है उनको मॉनिटर किया जा रहा है, बट स्टिल व्हेन द अटेंडेंट आस्क्ड देम कि जी हाँ जी अब नेक्स्ट कोर्स ऑफ एक्शन क्या है, तो मैं डॉक्टर राघवन से पूछ के बताती हूँ, वो वहां पे उस चीज को खुद से भी डील कर सकती थी, वो बता सकती थी, क्योंकि वो बार बार आके तो देख रही थी, क्योंकि देयर वाज दिस लाइन दैट शी वाज स्कैनिंग कि क्या चल रहा है, बट क्योंकि उनको किसी ने देखा नहीं और उन्होंने खुद से फैमिली के साथ भी डिस्कशन नहीं किया, सो एवरीबडी वाज इन दिस ग्रे एरिया कि जी हमें तो कोई नोटिस ही नहीं कर रहा, हमारी तो कोई केयर ही नहीं कर रहा है यहाँ पे.
I think, Lavanya, you have brought in a good point where, although we all know that nurses are not supposed to be updating about the patient's condition, because that's a communication that has to come from the doctor. I agree, but at the same time, like you pointed out, that at least, I mean, they could have at least communicated that yes, the patient is under observation, and Dr. Raghavan will come up to you and explain you the situation. But what about the doctor? Why do you think? I mean, we do not communicate, or we do. I know in corporate hospital that's not true. So I think in your hospitals, mostly you would be actually sitting with the patient party and explaining. I can see Dr. Mehul was not okay with the whole idea that this is not something that we do. We rather sit with the patient's family and explain them everything.
I
So
would
you
never have a situation like this in my unit. Could never
Yeah.
happen.
But if I talk about government hospitals, and if I talk about even small setups where not enough time and attention is given to the family members, where they are explained about what it is and what we are doing, so maybe you must be finding it out of context, so that's where probably you were not able to relate with
No
the.
matter, but even in municipal, I've done all my undergraduation from a municipal corporation. There are only two things. One is the doctor is overwhelmed with work. We've had situations where we've been working for more than 72 hours at a stretch. And unfortunately, at those situations, we take things for granted. I don't see in my career a situation where we've ever had a situation where a person has come in with a chest pain and we've not able to even give him one sentence of solace. I find that a little harsh. B, I do agree what everybody said, and I think this is one thing which is a part of India or a Southeast Asia. If this situation was in overseas, the nurse would definitely stop the doctor at the door and say, you need to update the patient.
But that's something is absolutely not existent in our
That's not
country.
existent in our country, and that independence or empowerment of the nurse is what we have started doing and we should be doing, because I think everybody, she may be a nurse, she may be a doctor, that doesn't mean that the person in a level of humanity is up or down. Everybody has, as a healthcare personnel, you are a team. You are explaining the relative about what is the problem, and they have a full right. Like the nurse also has a right to give the right but limited information according to what her capacities and capabilities are.
But I think we are miles away, Dr. Mehul, from this.
Madam, I think the mindset needs to be changed.
Of course.
If the mindset does not start, we will never start, because every time we are just hearing this, that we are 50 years behind the West. It can't happen. Rome will never be built.
I agree. So in our individual capacities, I think the doctors need to be more, accommodating and, respectful towards nurses. Nurses need to, first of all, acquire enough knowledge and confidence and communication skill and involvement and engagement. And then also communication to assert that I'm a patient's advocate and I'm supposed to be, making sure that my patient is looked after. But I'm talking about the reality. So this particular situation that we have picked up, and I'm suddenly reminded of my husband's uncle who was admitted in one of the government hospital. It was middle of night. We were away. My husband and me, we were not at home. They were living very next door to us, but we were unfortunately not at home, at that time. So he was taken to one of the government hospitals, at night time, in the middle of the time. So the patient was seen by the doctor it was identified that he had MI, and he was in the bed, he was still in the emergency, still was to be moved to the critical care area. Unfortunately, he said, I want to use the toilet. And the nurse said, you can go. He went to the toilet and collapsed. Now, forget about updating the family, informing the family, even remembering that can we send the MI patient to the toilet. So you can well imagine the reality I'm talking about. There are all sorts of examples. I know in hospitals like Reliance and Fortis and Max, and I'm sure we have counseling rooms where patients, family members are called and everything is explained. But they are just handful of hospitals. Majority of the hospitals are very, very different. Even recently I read a news, in article in a newspaper, that a patient had to literally go to the court to request, please update us about the patient's condition. We are not getting updated about patient's condition. So the court actually sent a instruction that every hospital should inform the family about patient's conditions. Of course, now we are doing that. I'm not saying we are not doing, but
during COVID time, this thing happened. During
yeah,
COVID time, most of the hospital
were
did the
communicating.
same thing. Yes,
Yeah.
ma'am.
Yeah.
They
But
did not
actually, there are
communicate
all
a
sorts of
single word.
stories. There are
Ma'am?
all sorts of stories. So COVID is an exception. I will not talk.
I'm saying even they did not communicate a single status of the patient.
Yeah,
There are
absolutely.
many hospitals, even private hospitals too. They did not communicate.
Yeah. I think they realize that's the only way to keep the society and population calm. Otherwise, it would be a chaotic situation. Another question that I want to ask all of you is, see, the patient's expectations change with time. Patients' expectations change with time. For example, when they entered the hospital, what was their expectation? Attend to my patient. They don't expect any communication. Please see whatever you can do, give prompt attention, whatever needs to be done, please look after, we'll see it. But with time, their expectation would change. And we need to understand that these changing expectations will have to be looked after simultaneously. So we do everything for the patient, and if we don't explain to the patient party what is being done, the usual assumption is that not enough is being done. And in case, unfortunately, if we lose the patient, or if there's some complication, they'll always say that nothing was done, my patient was lying there, nobody attended to. Well, unfortunately, suppose if this patient, Mr. Abdul, passed away. Now tell me what will be the family's assumption in that situation. 110% they're going to say, doctor just came once, he never came back. Only it was nurses who were coming in and out. We don't know what they were doing. They did not tell us anything. So nobody attended my patient, and that's why my patient passed away. Now imagine, because we are not communicating, we are not letting them know what is the situation, what we are doing, what is the likelihood, why we have put the patient on observation. So that communication could actually resolve a lot of issues, because the confusion would be kind of looked after. Another thing, one, there was no communication, so there was a lot of assumption. The story was created by the family that nothing is being done. And as I said, if the patient died in that case, 100% they'll go and talk. Though it's a useless hospital, nobody comes to see the patient, they'll admit you once, they'll charge you heavily, and nobody will look after your patient. Second thing is, when nurse went and talked to the doctor, did you see the change in her version of the story? Did the patient's family member really meant that oh, we are getting bored and we want to go and we are not comfortable? So all that is also very common. When we pass on some information to another person, we do a lot of editing. And that's so unsafe, because it created impression in the doctor's mind that the patient family does not care for the patient. Again, even this can be a reason for conflict. He may come back and say, are you here? Are you looking for comfort, or you're looking for your husband's health? That itself could ensue into an argument. And over and above that, if you saw the way doctor reacted to it, Again, in a very, very unprofessional way, he said, oh, that lady thinks of herself that she's here for her comfort and not for her husband. And a lot of time we do this kind of talking. I think it's time that we need to work on our communication, understand their expectation. How much time would have it taken for the doctor to update? Not more than 2-3 minutes. But that 2 minutes of communication with the family could have prevented lot of conflict, aggressive reaction, confusion. So I was interacting with the CMO of AIMS. I just happened to know him. He just visited me once, and I asked him, how many times have you had, a situation where the patient's family became aggressive with you? He said, not even once. I said, how come? Yours is more like a government hospital. It's crowded all the time. He said, every time we have a patient who is in critical condition, while my team is settling the patient, I would always go and talk to the family members. I will try to gather more information. Or if I have some information to be shared with the family, I would go and talk to them and explain them that this is the situation, this is what is being done, and this is the process, or this is what we are planning to do. Now, that attending to the patient is important, but communication here is also equally important. Another CMO with whom I spoke, she said, I would always, once I take the patient in, I will tell the relatives, please wait outside. Let us settle the patient. I will come back to you and talk to you and explain you everything. So again, when you communicate like this, the family knows that, okay, they are going to work on the patient. Once the patient is okay, they are going to, come and explain to. And she said, every time after we settle the patient, I will go out and I'll say, okay, whoever is the first, family members of the patient, please come. I want to update you about the patient condition. And the whole confusion is over. So even if you think the condition is critical, even if you think the outcome is unlikely, I would say if you update them and you let them know that this is what we have done, but this is still pending, or this is going to happen, but these are the warning signs. So we have to keep our fingers crossed and wait for another couple of hours to see how the situation changes its. So in a way, you are preparing them for any eventuality. So if you tell them, we have done everything, we are doing everything, but the patient is still not, out of danger. So in a way, you are preparing them for the second news, which could be complication or death or bleed or surgery or whatever it is. That's the, importance of communication, especially in such situation where it's a sudden some health issue, death, or not death, I mean injury or road traffic accident or bleeding or some burn case or some sudden medical emergency. There it becomes all the more important to communicate with the patient. So at this point, I want to share the presentation with you and take through the presentation and also help you understand how do we really get deeper into patients' expectations. So give me a second to show you the presentation. 1 second. Okay, so according to a recent survey by ICC, CRMAA, and Taragini, they have actually, reported that almost 45 to 50% of the patients and their family members feel that they are not, empowered in the patient's treatment. They also expressed inadequate clarity on diagnosis, and they reported the consultation to be rushed one. At the same time, they perceived lack of involvement in deciding the treatment. So just today, my niece got her, surgery done in one of the hospitals. I'll not name the hospital. So I called her husband. I said, what is this surgery? He said, I don't know. The doctor said there will be 2 surgeries. One will be done and then we will be doing the second surgery. I said, they must have given you some information about the surgery. He said, I don't have clarity. And it's one of the premier institutes where the patient is getting operated. So, I mean, these are all very real life examples that we all happen to see day in, day out. So, as a result, the patient and the family would not have clarity on what treatment it is or what are the care options. Almost 1/3 of the patients and their family members indicated that they were not allowed to describe their conditions or symptoms. We all know that we do not like patients who talk a lot. Most of us either stop them, interrupt them, or ask them leading question or close-ended question to kind of cut the story short. And I'm sure you remember, how much time do we really give to the patient to speak uninterrupted? Do you remember the figure? Any idea? Guess? And how much time do we interrupt the patient? No idea? Almost 10 to 11 seconds. Almost. So we don't allow the patient to speak. Almost the same number said the doctor did not straightforwardly address their questions and doubts. Again, when patients start asking, what is the risk in this surgery? What are the possible complications? Is there a possibility of relapse? Or what if we want to go for second opinion? Is this surgery really, is really, really important? So when they ask these questions, and if you're able to give them a satisfactory answer, they'll be convinced and they'll be happy. But we all know that we are not very happy answering a lot of questions because we feel uncomfortable, discussing at length with the patient and their family members. So in general, I think patients really expect that they should be allowed to narrate at least their problem in their words and to be heard attentively. And as I mentioned earlier also, on an average, we interrupt our patients within 11 seconds of what they start talking about their problem. So nobody can talk about their problem in 10 to 11 seconds. We normally assume that if we allow them to talk, they will take longer. So any idea in how much time can a patient on an average tell about their problem? Guess?
7 minutes.
7 minutes? Okay. Any other guess?
Depend upon patient condition. If he
Absolutely.
or she is in pain, how he will take such a long time to explain. Just he will say, my abdomen is paining, or like I'm getting the pain. That's all.
The thing is, if you allow them to speak about their problem, tell me what is it? They would, studies suggest that most of the patients are able to talk about their problem in 60 to 80 seconds. So if you see me speaking, you can actually speak 10 to 12 sentences in one minute or so, which is good enough an opportunity for a patient to tell about their problem. Of course, you will be asking more questions and patient will be answering further. But if they're given that 1 minute to talk about their problem in their words, and if you really, really listen to them, studies suggest that you get almost 50% of the diagnosis, provided we ask right questions, we allow them to speak, and we listen to them. But a lot of time, we do not give them a chance to talk about their problem because we feel that we understand it and we know it already. For example, if a patient comes with shoulder dislocation, you can make out right from distance, oh, this patient has shoulder dislocation. Now patient wants to tell you how actually it happened. So the patient wants to say, doctor sahab, maine aise jaise haath uthaya, my shoulder went out of place. And if it's a regular and a chronic kind of a case, but we think that we know it and we say, nahi, chup kar jao, we know what the problem is. So they feel suffocated when they're not able to talk about the problem. The second common expectations patient would have is that they want to be explained in simple and understandable manner. Incidentally, studies suggest that we use a lot of technical jargon. As a result, they don't understand much. So I want you to read this paragraph with me.
Ma'am, speed. Madam, I could not able to read completely. Oxygen, carbon dioxide, and that's all.
So how many of you could make sense of what I was showing you?
It was something related to rust, the process of how rust forms.
Process of rust formation.
This is what exactly happens with the patients and patients party when you explain them about their disease, diagnosis, treatment, procedure, prognosis. 50% of them do not understand much, but they'll be nodding. Yes. Because they don't want to be considered, less intelligent by acting that they are not getting it. So they'll be nodding, saying that, yes, I understand, but actually, honestly, they would not understand much. It's very important to understand that when we explain to the patient, the quality of information has to be with the understanding of the patient's, patient and the family's level. And as a result, if you are able to put the information in a manner that makes sense to them, it would actually maximize outcome, because when they understand, not only they comply, but they also are ready for the outcome. Patients expect to know in detail about their illness. Studies suggest that almost 57% of the patients who had cancer, they wanted to talk about the life expectancy, but in reality only 27% of the patients could get clarity on this particular topic. 63% of the patients wanted to discuss the effect of cancer on their other aspects of life, but in reality only 35% of the patients could actually get more clarity on how this cancer is going to affect them and their life. So patients have very high information need. Studies suggest that almost 98 to 100% of the patients want to be very clear about their diagnosis, and they prefer as much information as possible. They also want to be involved in decision making. They want to know what are the options available and what would suit them best. They would like to talk and discuss and get involved in decision making. But studies suggest very few of us actually like to practice shared decision making. A lot of us think that it is not appropriate to discuss every situation. Whereas people who practice and advocate shared decision making, they believe that in almost every situation you can engage the patient and help them take a call. Of course, it's a little longer way, but then that's how the patient would feel that they have been given enough explanation, and also they were given the choice to choose. I remember I was taking a session for a group of anesthetists. So one of them shared his experience. He said, I had a patient in my clinic. It was a government hospital I'm talking about. So he said a lady must be around 50 years. She was high diabetic, and she had to undergo foot amputation, and she was sent to the anesthetist for PAC. So while doing PAC, in a very casual way, he asked the patient, कहाँ से काटेंगे पैर आपका? And that lady was completely shocked. She said, पैर काटेंगे? मुझे तो किसी ने नहीं बताया कि मेरा पैर काटेंगे. That anesthetists was suddenly, he became alert. He kind of changed this, Now imagine you have already planned foot amputation. I'm sure that must be the last choice. That's why you have planned it. But what about the mental preparation of the patient? What about letting the patient know that this is the only choice? And then, see, even if you lose this small part of your finger, which probably do not play much role in your day-to-day activity, losing this is a trauma, disfigurement. A lady, I mean, how will she work? How will she walk around? How will she do her household chores? So discussing about it, explaining to her how you are going to handle it and how you are going to rehabilitate her, all that requires time, mental acceptance. But you have decided to do something. Of course, you will not be amputating. I know you will be taking consent and explaining, but the patient also requires time to accept such a big decision. The problem is when we practice shared decision making, it requires time, it requires patience, it requires negotiation skills. A lot of us are short of those skills, so we prefer to be to the point and not talk much. But studies suggest that patients really look forward to knowing more about their condition, especially, if it is something very serious. Patients would expect that those sensitive issues should be handled with more care. On the other side, almost like 70-80% of the patients and their family members reported that their encounter about breaking bad news was suboptimal, where they didn't find the treating team very sensitive and compassionate, and who did not balance between sensitivity and honesty. Although we all say that you should be very honest and you should tell all the information to the patient very clearly and don't give them any false hopes, but then at the same time we need to be sensitive and remember that that's going to affect the patient party. So that clearly shows that there's a huge gap between what we are delivering and what the patient is expecting from us. Now, if I may ask you this question, what are the common expectations of the patients? Can you write in the chat box? Write in the chat box, what are the common expectations? Complete picture, absolutely. Information about the treatment. Be transparent in treatment. Yes, that's one expectation every patient has, that please be transparent with me. Okay. What do others say? Clarify the doubts. Information about the treatment. I think information need is primary need of every patient. If you see, even when all of you are writing, information need is that's the most important need according to the patient's point of view. That all disease can be cured. Yes, that's an unrealistic expectation that they will have. I think even when we are in that place, we also, have the same expectation, isn't it? Isn't that true? That's how the human mind functions. We are over optimistic. We are hoping, wishful thinking that every problem should have a solution. Absolutely. So see, a lot of you have written about give me assurance. Then what is it? Okay, course of treatment in very easy language, and also information need, clarify my doubt, explain to me, explain to my attendant, information about the treatment, complete picture. So that means actually every patient looks for ease of communication, someone responsible to listen and address their concern. Also, they look forward to compassionate and empathetic behavior from all of us, where the patient is treated, with concern, care, and compassion. Then access to information. They really want to know clear picture, clear explanation, and like even knowing about their condition in a very simple and clear manner. In case if the patient has any need, for example, patient is experiencing pain or discomfort or any change in the condition, they want prompt attention to the patient's health need. A lot of time we do not we do not attend to the patient's needs seriously, and that actually ends up into a very serious complication. I'll share one, experience with you, and of course, safe and comfortable environment. Absolutely. So see, I remember in one of the hospitals, incidentally, on that particular day, I was there in the hospital. I'd gone there to do a program, and I was in the MS office when this whole thing happened. Now, this lady, she was incidentally wife of one of the hospital employee. Again, this is a government hospital. Pardon me for bringing in government hospital examples, because that's where the reality lies. That's where the truth lies. And then this lady, she delivered a normal, healthy child. She was moved to the ward, and after say, a couple of hours, she felt that she's bleeding more than normal. So she asked her mother or mother-in-law to go and report the, doctors or nurses, whoever was on duty. So she went and told that my daughter or daughter-in-law is saying that probably she's bleeding more than normal. Somebody came to see, but nobody kind of took it very seriously, and they said she's fine, don't worry, this is nothing very big. After again, after a while, again she felt that no, it's not normal. She asked her mother to go and talk to the doctor or nurses, but because they had seen once and they thought it's nothing very major and she's just creating fuss, nobody came to see her. After a couple of hours, this lady went into full-blown PPH. By the time they realized, she had already gone. They tried to resuscitate, they tried to do everything, leaving her one day, not even one day, few hours old child. That lady passed. And we can't deny that these things don't happen under our eyes. So patients' complaints, a lot of time we don't take seriously. I'm sure you also must have had some, incidents where patients reported something and we didn't take it seriously. And later on, we either lost the patient or we had very serious complications. So that's because when we don't listen to them or we don't take their complaints seriously, that's where these kind of, things that can happen. So they expect prompt attention to patients' health need and, of course, safe and comfortable environment. Now, my question to you is, tell me, are these expectations unrealistic or they are new? And as I said earlier, to start with, when I said, if you were a patient, I think these were your expectations as well. When you made the list of the expectations, nothing is unrealistic. Maybe they would have wishful thinking, which we say it's an unrealistic expectation. We have to address even that part. If they say, डॉक्टर साहब मेरे बच्चे को बचा लीजिए, कितना भी पैसा लग जाए, पर मेरे बच्चे को कुछ होना नहीं चाहिए. If they say something like this, that means they need to be explained. That this is the situation, this is the likelihood. We are doing whatever best can be done. We are following all treatment protocols, but we cannot give you guarantee for the outcome because this is the situation. Now, when you don't attend to these, when you don't address these expectations, what are the consequences? It could be realistic, it would be unrealistic. What do you think are the consequences of unaddressed expectations? Write in the chat box. What all can happen if we don't address their expectations? Yes, they get agitated. They lose trust. Absolutely. Conflicts, complaints, chaos. Absolutely. There'll be a lot of chaos. Anxiety, anger, frustration, paranoia. Yes, a lot of doubt and blame game and allegation, especially for negligence. And then patient will get aggressive or overreact in case of any bad news. Absolutely. And they'll accuse you for being negligent. Because if you have not been able to explain to them or communicate to them, and their expectations are not met, and there's a huge gap, I'm sure they will be very, very dissatisfied with us. So a lot of time when their, expectations are not met, one is they will be dissatisfied. Of course, there are all possibilities of conflicts, frequent conflicts rather. You can also, expect reduced footfall if a lot of people are dissatisfied with you. There are few number, maybe they'll come and go, but if a lot of people are dissatisfied with you, you will actually be able to visibly experience reduced footfall. Bad reviews, that's another challenge now. Nobody goes to the Google and write good reviews, but bad reviews people are very, very prone to, because if they cannot shout at you, if they cannot fight with you, they would go and just write one bad review for you, either for you or for your hospital, and your reputation is gone. And we all know 50% of the patients read your reviews before they come to you. And the next generation is going to be much more than this, because now they believe in first knowing the doctor or the hospital before they visit you. Of course, there's a risk of violence and aggressive reaction, because if they have uncontrolled anger, suppose if the person himself, patient or the attendant himself, is very aggressive in nature, even in such situation, they can become argumentative and aggressive with you. This risk of litigation, that's another problem that we have to be now ready for, because now they're aware of even their rights. And they know that we are very poor in knowing about patients' rights. So that's where they nail the hospital and the doctor. And I was taking a session for a Center for Mediation and Conciliation. So they have organized a program for doctor-patient, conflict resolution, that is mediation program. So a lot of doctors are attending that program. It's a 40 hours mediation program. So there we are discussing this, that when they think that they want to litigate a hospital, there are a lot of lawyers available to guide them, to tell them how they can actually implicate any hospital or, doctor. So that problem is now, increasing day by day. Of course, all that will lead to reduced professional satisfaction among staff member. So if we could understand the expectations of the patient, I can see some answers in the chat box. Let me please read. Yes, bad word of mouth marketing. I completely agree. And then, of course, code violate. Yes. Yes. Good evening, Dr. Priyanka. Good evening. Yeah. Okay. So if we could understand, if we could classify these expectations and make sure that at least those expectations that need to be fulfilled, that can actually create satisfaction, if we could do that, I think we will be able to meet our patients midway. So I got this interesting model, that's Kano's model of managing patients' expectation. So this model I have adopted from from retail, from not from health. This is not from healthcare, but I found it very relevant, applicable, and then I modified its content to suit our requirement. So this model says that anybody's expectation can be divided in 3 categories. The first one is basic expectation. So when we say basic expectation, this is an expectation which is unspoken. Patient will not say that I expect this from you, and they expect it to be satisfied. When these expectations are met, they are not going to come and say you thank you, you have met my basic need. They will not even acknowledge. But when these expectations are not met, they are going to be dissatisfied. So can you think of some expectation that we can consider as basic expectation, for which they are not going to come and thank us, but then these expectations have to be met? You can write in the chat box, and we have more answers when you write in the chat box. So, okay, being respectful. Mariam says being respectful is one of the basic expectations they'll have. Okay, fine. What do others say? Write in the chat box. Give information. Okay, yes. Explaining in detail. That's also something that they will expect. Check the patient. Yes. Being heard. Okay. humble and layman language, explained in in an easy, understandable manner. Absolutely. So if it is an OPD, for example, so they would expect reasonable waiting time. If there is a reasonable waiting time, they'll not come and thank you, your waiting time is very reasonable. But if it is reasonable, they are okay, they are satisfied. When they come, the doctor is available, the staff is available, the staff is talking to them, ready to attend to them. So all these are basic expectation. The staff is paying attention. They don't have to wait for the doctor to come. Otherwise, I remember earlier it used to be like 2 to 3 hours patients were waiting, and they'll say, oh, doctor sahab abhi aa rahe hain, doctor sahab abhi aa rahe hain, doctor, and patient would wait. But today we all know patient will run away if you make your patient wait. So when you ask them about their problem, when you kind of get their information, uh, or when you are when you do your assessment, so all these are all basic expectations. We have to do it, if we want our patient to be satisfied. So it's nothing very special that we are doing. We have to make sure that these expectations are met. The second set of expectation is called satisfier or performer. And if we can look after these needs, let me tell you, most of your patients will be more than happy. If you can identify these needs and if you can fulfill them, they are going to be very, very happy. They will not even hesitate if you ask them to write a good review about you. So these are the expectations. Somebody's device is on unmute mode. Can I request you to mute your device? Because there's some background voice, so if that can be controlled. Yeah. So these are the expectations. When they are met, clients are happy, patients are happy, their family members are happy. Also, when these expectations are not met, again, they're going to be dissatisfied and they're going to come and complain to you that this thing is not there. Can you give some examples? If it's an indoor, for example, you have admitted a patient. So what are the performer or satisfier, factors that the patient will be happy, satisfied? Room is neat and clean. So very nice. Room is very nice. Spacious. Ventilate. AC is working. Toilets are clean. Okay. Taking care of diet. Okay. Faster checking by indoor doctor. Okay. Patient was attended, immediately by somebody, resident. Okay. Then daily update about the treatment. Okay. Informed about plan. So yes, if they are shared that information, they are happy. Okay, whatever, like if you're updating them and also sharing the plan of action, they're happy that you have updated them. Great. So guiding the attendant with billing process and admission process. Yes, that also they are happy. You explained me properly. Yes. Good outcome of admission. Yes, if the outcome is good, definitely they are going to be very, very happy. So simple things like if the staff's behavior is welcoming, compassionate, attentive, prompt, so they feel that the staff is really very well behaved. If the staff is courteous, again, they're very happy with the staff's behavior. Waiting time is minimum. The moment they enter and they know this was my time for appointment and they have been attended, they're happy that they were not made to wait. Also, if somebody is attending to them with full attention, for example, now we have appointed patient care coordinators. So the whole idea is that somebody should be able to give full attention to the patient's requirement and fulfill those needs. And then also allowing the patient to narrate their problem. So if they have something to talk about, if somebody is ready to listen and they're able to narrate their problem, they feel very happy. Doctor साहब ने मेरी पूरी बात बहुत ध्यान से सुनी. उन्होंने पूरा time दिया. He allowed me to talk about my problem. And also when you allow your patients to ask questions and when you answer them with patience. So these are, real performers or satisfier. So I remember I had, sent One second, I think there's one more point, if I'm not wrong. Yeah. So somebody attending to the patient's needs promptly. So I remember I had sent a relative of mine to a friend of mine who's a gynecologist. So this lady had to undergo hysterosalpingiography. And she had been to 2-3 doctors, but she and her husband were not very satisfied, and they were not very, ready for going there. So I sent them to this friend of mine who's a gynecologist. Now this both husband and wife, they asked a lot of questions, but she answered with lot of patience. In the end, the husband of this patient, she said, "Doctor, we are very sorry. We asked you a lot of questions." And her reply was, "It's perfectly all right. You are paying me for it, and it's my duty to answer your questions." The very next day, the patient got the surgery or the procedure done by her. So it is not only that the patient is satisfied, they are more likely to stick with you if they feel that you are accessible and you are willing to spend time if it needs to be explained or answering their concern. So if you are able to do this, trust me, your patient is all yours. Now in all this, if you see, it is a lot to do with communication and interpersonal skills. Most of the times, if the conduct of the patient, the staff and the treating team is good, they are more than happy. Even if there is small deficiency in this service, they don't mind overlooking. On the other side, if the behavior is not good, even small service not available becomes a very big issue. And also, like Mariam says, there will be compliant to the advice. Absolutely, yes, because now they know that they don't want to miss on this opportunity or this relationship. The third category of patients' expectations can be called delighters. So delighters are that there's a requirement, but patient does not expect that requirement to be met. But when that expectation is met, it becomes a delight. So it comes as a pleasant surprise when that requirement of the patient is fulfilled. Can you um, give me an example of delighter? Can you give some examples of delighter? Okay, there's an answer in the chat box. Okay, patient's birthday celebration. Yes, this I'm seeing very often happening in hospitals. If they know it's patient's birthday, so they'll get a cake and a card, and the team will come and they will kind of celebrate. Yes, this I have seen. I've also seen arranging photography for newborn. So they have a photographer who is on their panel who would come the moment child is born. So that photographer will capture, and with a lot of props actually. A room upgradation. Yes, that's also a pleasure for them if you say, okay, we'll upgrade your package up or give you better room. Absolutely. Decorated car to go home for both mom and baby. So Archana, have you seen something like this? I have not seen. Have you seen something like this? Oh, great. Unmute your device and speak.
We planned and we implemented in one of the corporate women and childcare hospital in Bangalore. But I think after few months of that, I have left Bangalore and shifted to Hyderabad. But yes, that was so delightful because everybody were doing cake cuttings, photo shoots and all. So we were given a task to do something much more than that to keep the because I was one of the team member who was actively involved with all the mothers and babies from the antenatal period. So this was for few of the premium package mothers we started actually.
Imagine.
And also we have one more service at current hospital. I would like to share that also. We have a spa, pedicure and manicure services for the mother before she goes home. But
that's interesting.
That's what just wanted to share that also. There is a spa, girls come. The spa girls come from outside. We have a this one. They do come. We have the
Wow.
pedicure, manicure, and a spa session for the mother before she goes out of her room
Wonderful.
while
So I
going
want
home.
some other activities that you're doing in your hospital that you think is a delight for the patient. Would some other like to share their experience or their activities that they are doing? I can see some answers here. Some hospitals like Cloud9 has baby shower. Oh, great. So fond farewell to patients. Okay. Our staff accompany the patient till the lobby and say bye to them. Okay, that's also good. Very nice. And then decorated cars, room upgradation. Okay. Okay. So anything else other than this? Okay, now baby shower is with all the mother and child care. Okay, so that means it is being done for like a regular thing. Yeah, okay. Anybody else who would like to share their experience in what special are you doing for your patient to delight your patient?
We,
Yeah.
when it comes up to organ donor, because I'm in the ICU, we have
Mm.
especially when the patients are brain dead, the family agrees on organ donation.
Mhm.
The patient is then wheeled out with a guard of honor from the operation theater all the way into the ambulance. They've been covered with, probably a, a type of a memento which is being given from, or something which is given from the hospital. And then flowers and the garlands are being, and then the ambulance is also somewhat decorated in a normal fashion, in a fashion which will be not looking too this thing. And then that's what we tend to do. The guards, then the security guards at the hospital do come up and give them a salute and a bit of you know uh, uh, a small, like it's like a small musical thing that they'll play for them. It's just like a guard of honor. That's it.
Oh, that's so good. That's so good. Yeah, wonderful. Thank you for sharing that. Yeah, I can see an answer by Mariam. I really liked it as I was sleep deprived as a new mother. Okay, they used to put a do not disturb sign on our room. Yes, that's also a good idea that nobody will disturb you. Good, good, good. And then a discount in the final bill. I think that would really, really plead them, but then please them. But I don't know how many hospitals will be really willing to do that. So some of the delighters in a very professional way, I'm saying, could be like informing the patient of rescheduled appointment. For example, for some reason, a patient's appointment is cancelled. So if you inform the patient, beforehand, so that their visit is saved rather than they come to the hospital and find out that the appointment is rescheduled. If you inform them before time, so it saves them a visit and also the travel time. So that's also one of the ways. So I can see an answer in the chat box: baby kit given complimentary. Yeah, this is another thing I see now. They provide complete kit to the for the baby. Yes. And then, of course, like you said, follow-up calls. Yes, I think this is what even I have written. So if the telephonically, if you follow up with the patient by the hospital staff, even that is something they are, they appreciate. Or when you are ready to spend little more time by asking and addressing their unspoken concern. So it could be little bit, not directly about the treatment or disease, but something that you think is related to it. And if you talk to them about this, they feel that, they are really very concerned and caring. And at times when you show that you remember their personal details like their name and their profession or where they live and what they do, even that also surprises them and it comes as a delight to them. So if not delighters, of course I know corporate hospitals are going to any length to create delight, but then if not delighter, if we can just focus on the basic and the satisfier category, most of your patients are going to go back happy. So 8, expectations that the patient would have, if they are well met, they're more than satisfied. One is communication with nurses. Second is communication with doctors. Communication about medicines. Because a lot of times there's a confusion about, what medicine to take and when to stop. If somebody can really, really explain them properly. Then responsiveness of the hospital staff. So when they need attention, if you give them attention, they're happy. Pain management. That's one thing. Again, if they stay in pain for longer, they feel that nobody's attending to my need. And of course, cleanliness and quietness of the hospital environment, discharge instructions and discharge timing also, and then overall hospital rating. So if all these things are looked after, they're more than happy. So at this stage, I want to introduce you to a very interesting concept, and that is concept of design thinking. So how many of you have heard of this concept of design thinking? Have you heard of design thinking? Anybody? No? No problem. So actually, design thinking is a process for solving problems by prioritizing the consumer's needs above all. Now, this as a problem solving tool is being taught at very prestigious universities like Stanford and Harvard, where, and it is not just in any particular specialty or industry. It is being used extensively right around you by organizations or MNCs like Amazon, Uber, VFast, Oyo, Zomato, and of course IHC also working on the same lines, where you are trying to meet your patients or the client's need or the consumer's need by keeping those needs on the priority. So you don't plan things or execute things just thinking that okay, this will be okay for my client or consumer, but you actually work to find out how that happens. So the concept of design thinking is being extensively used across the world by various industries and organizations, because they have now realized you may be giving your best. It's something like, you come home and somebody is offering you juice, but you are thirsty and you want water, and you just want water, and somebody's offering you juice and something good to eat, but you want something very different. So why not understand what do my consumer or customer needs? So design thinking has been simplified by these 5 steps. Give me a second to change these slides. Yeah. So there are 5 steps in design thinking. The first step is empathize. When you try to develop a deep understanding of your consumers' challenges. So when they try to, avail your services, what are the challenges that they experience? What are the hurdles they experience? If you develop a deep understanding of those challenges, then you will clearly know what is the problem and what is the problem I should be, addressing. So second step is defining the problem. Now, once you are able to clearly define the problem, the third step is ideate. Ideate is when you brainstorm and create ideas and solutions to solve that problem. And for ideation, you not only use your industry people, but you also engage people from different industries who would have different perspectives to add to what you are thinking. Because as a healthcare provider, we have a very a specific way of looking at things. But when you have people from different industries, they're able to give a lot of new perspectives and ideas. So the whole concept of creating comfortable hospitals for not only the patient but for the attendant comes from hospitality. And when you have integrated hospital with hospitality, you get to see such comfortable hospitals, not only for the patient, but for their family members also. So when you ideate, a lot of ideas come in to solve the problem. And then from those ideas, you come up with 1 or 2, prototypes that you think will work to solve the problem. And then you apply that prototype to one particular area. And if that works, then you generalize it. So let me take you to the first stage. Maybe we will not be able to cover all 5 stages because you all come from different hospitals, but I can make the beginning with you to help you empathize with your patient. So all of you have a copy and a pen with you? And can I request everyone to have your cameras on? Yeah. Yeah, please have your cameras on. Okay, so I'm going to take you to your hospital's OPD. I'm sure all of you must be familiar with your hospital OPD. So I'm going to take you to your hospital OPD. I want you to, go with me with the eyes of your mind and then visualize yourself in that area because you are familiar with your hospital, place and direction and position and geographic, plan. Just go with me. So imagine yourself, entering the hospital not as a staff, but as a patient. Now, assume that you are a patient. You are not familiar with anybody. Nobody knows you. You don't know anybody. You have taken an appointment for a consultation, and you are visiting your hospital, OPD for a consultation. So imagine yourself entering the hospital gate as a patient for an appointment. Now, first of all, see yourself in the parking area because you enter the hospital and you go to park your car. You're not a hospital employee, so parking person does not know you. See what expectations you have from the parking fellow. Are your expectations met? Also look at the parking area. How does it look? Are you satisfied with its upkeep? Also, note down what challenges you experienced in availing the parking facility. See yourself at the reception of the hospital. Just 1 second. I'm sorry. Yeah. So now see yourself at the reception. You go to the reception to confirm your appointment and also confirm if the doctor is available. Your appointment is confirmed and you're directed to wait in the waiting area. There are already other patients, and you have also been informed that it will take at least half an hour to 45 minutes. There are around 3-4 patients before you. Again, check your expectations that you had from the receptionist regarding her or his interaction with you. Were those expectations met? Also look at the physical setup of the reception and registration counter. Are you satisfied? Also note down what challenges you experienced in availing these services of the receptionist. Now look at the waiting area. You have come to the waiting area. Look for a place to sit. How do you find your waiting area? Is it comfortable? Are you happy? Look at the ventilation, light, entry, exit, seats. Is everything comfortable? Okay. Satisfactory? Are you happy waiting in the waiting area? Note down what challenges you experienced in the waiting area. Are you okay with the waiting time? Note down. Your turn has come for consultation. You're visiting your doctor. Since you're not working there, so you don't know the doctor. What is the quality of interaction that you experienced with your doctor? Did you get enough time and opportunity to talk about your problem? Were your expectations met in terms of your communication needs and information needs? How satisfied are you after meeting your treating doctor? You have been asked to get some blood work done by your doctor. See yourself at the hospital lab. Try to see the arrangement and overall upkeep of the place. Are you satisfied with the upkeep and the location and also overall handling of the patients? Also note down what challenges you experienced in availing the services of the hospital lab, about cleanliness, waiting area, behavior of the uh, technician or the person who is registering you for lab, all that overall. After the lab work, you go to the hospital pharmacy to buy the medicines your doctor has prescribed. Again, try to focus on the overall appearance of the pharmacy, comfort in reaching the place, facilities available for you and other patients, ventilation, behavior of the person who is dispensing the medicine and who's billing at the pharmacy. Did your pharmacist explain you the dosage and other things about medicines? How satisfied are you with the services of your pharmacy as a patient? Also note down what challenges you experienced in availing the services of the hospital pharmacy. Before you return to the car parking, you feel the need to use the restroom. How many of you have actually visited the patient's restroom and used it? Okay, good. So now you have gone to the patient's toilet. Rate your experience of the patient's toilet. Go to the parking area, sit in your car, and reflect on your experience of your visit to your hospital OPD. Segregate these expectations as realistic and unrealistic. Rate your hospital OPD on a scale of 0 to 10, 10 being the best. Would somebody like to share their experience?
Madam, can I?
Okay, go ahead, please.
Yeah, well, first of all, you told toilet. Yes, I go because I have to check the, all infection and all with my infection quality control. So when I visit, patient toilet, most of the time, as per NABH, we have to clean the toilet 1 hour every 1 hour. Okay, they don't do that because it's a third party. We have taken third party, so they don't do. They go अपने मनमानी करते रहते हैं. they हाँ कर लेंगे, अभी करेंगे, हाँ मैडम इधर खाली ये ऐसे हो गया, अच्छा अभी साफ कर रहे हैं. दैट इज द थिंग. तो ऑब्वियसली मैं कोई भी बाथरूम में ना जाऊं तो मुझे पता भी नहीं चलेगा कि वेदर इट इज गॉट वॉश्ड और नॉट और क्लीन प्रॉपर्ली. फर्स्ट पॉइंट. Then secondly, ma'am, in pharmacy also, कि जो फार्मेसी में नॉर्मली क्या बिहेव होते हैं, क्योंकि ओपीडी आईपीडी एनीवे वी सेग्रीगेटेड. IPD will be taken by the endo patient different pharmacy area. But the thing is OPD area क्या होता है कि बहुत crowded रहता है comparatively to IPD. Okay, तो उसमें क्या होता है क्योंकि बाहर से
hold on, Nivedita, hold on. What I want you to reflect on is this journey. I made you, walk with your patient. I just want you to reflect on that. I don't want the details.
Okay.
I want you to let somebody else now try and you think how you want to reflect. But I want somebody else to reflect. Going as a patient to your hospital, what thoughts and emotions did that trigger? If you can share that with me.
Yeah, can I?
Sure.
Yeah. So going as a patient, first thing, car parking would be little tricky if
I don't want details.
Fine. So what difficulties I would face?
No. Did it trigger some thought process? Oh, we don't really look after this.
Yes. I just wanted to talk about parking. That's the reason I spoke.
Okay.
Because it is more chaotic and no guidance will be there. So as staff also we face sometimes. So obviously patients must be facing. That is one area. Another area where I felt right now is billing counter where there are always long queues. These are the two areas. And one more important thing, waiting area, what you are talking, everything is fine. We have enough seats, people do sit and wait, but there is to the whole, like it is a huge OPD area. And we have only one set of washrooms and only one set of drinking water.
Okay, hold on, Archana. Now I want everybody to write in the chat box one area where you could identify a problem. Write in the chat box one area where you could identify a problem. Great. So I can see some answers in the chat box. Wonderful. Okay. Jayapriya says all areas. Okay. Archana says billing counter. Satyapal says OPD and waiting. Bobby says washroom. Dr. Mehul says billing. Dr. Neha says long lines in pharmacy. Nivedita says pharmacy. Dr. Priyanka says pharmacy. Delays happen as insurance approval takes often time, long time. Again, Anas says waiting area, pharmacy line, washroom, parking, even in parking area. So friends, if you have been able to identify more than one areas, that's also possible. And if you have been able to identify one area, I have helped you with the first phase of design thinking, and that is identifying where the problem lies. So, what we have done just now, I made you walk with your patient from one to just one area. Similarly, you could have a similar patient mapping or walking where you could be in the indoor or for OT or labor room or ICU. So that is empathizing. Empathizing is not like verbal service. Oh, I understand you have a lot of problem. No. Empathizing is when you walk in the patient's shoe and you see where the shoe pinches. So I made you do this activity to help you with the first phase. The second one is now you can define what problem do you want to focus on. If you have identified only one point, we'll start working on it. If you have identified 2, 3, don't work on all 2, 3. Pick up one which is easy to fulfill, which is easy to look into, which is easy to resolve. And then on that, start creating ideas. And not just your ideas, take ideas from others from your hospital, your team members, patients, their family members. Generally talk to your own family members and ask, if I'm facing this problem, what do you think? How can I handle this? So create lot of ideas. And then when you will brainstorm on these ideas, you will be able to come up with one possible solution that you think will work. So at this stage, I want to introduce you to a beautiful concept called create. Have I discussed this with all of you anytime earlier? No. Any questions till this point?
So does it mean anticipating the problems before they happen, like design thinking? Try to troubleshoot before, or?
See, design thinking could be when you try to look at the situation from the user
like
point.
creating more foolproof systems, so we are reducing the chances of error, because however much you try, patients will always have something to complain about.
Yeah.
So just try to
to ease out. See, for example, when we had just shops to buy things, so the person who thought of online stores, see how they are developing and changing and modifying their strategies every day. Earlier they said cash on delivery. Then they said, okay, you can make online payment. Then we want to refund, we want to replace, we want to return. Whatever the customer wanted, they tried to integrate that in their services. And more the services now there are options available that if you like a car, you just pay for it, they'll come and deliver you the car at home. I had to buy a car and the car was at Gurgaon. It is little for like 35-40 kilometers. I said, I can't come there. I can see the car in this showroom, and if I like the car, I'll make you the payment. You send me the car. That's what they did for me. I did not go to the showroom at all. I just visited the showroom that is closer to me, because going to Gurgaon and looking for a car means one full day is gone. So when you are a service provider, first of all, I think we have to come out of that mindset that the patient's expectations are unrealistic. If you were a patient, you will have a same expectation. When you can have, why can't patient have? They are human.
I disagree. Sometimes as doctors, we are willing to wait for 2 hours. I have waited for 2 hours for the pediatrician, even if my appointment time was there. Yeah. But same thing with patients, even 30 minutes.
See, again, we don't know what their circumstances are. Maybe that is one. Second is, you being a doctor, you know the plight of doctors. You know their life. The doctor must be really busy somewhere, otherwise he would not make me wait. And another problem, very often, Dr. Priyanka, that happens with us is we have a tendency to condemn other professions. अगर मैं आज आपको बैंकर्स के बारे में बात करूं, if I tell you government sector में क्या होता है, if I ask you कि electricity department में क्या होता है, if I ask you if you go to water department, what service do you expect, I think none of us will talk any good words, except some services that has really changed. For example, passport service has really changed in our country. So we all talk gaga about it. Airports have become better. Now you go to the airport, it shows at which gate, how much time it will take you to enter. And this time when I was coming from, where did I come from? I think Bangalore. Another beautiful experience that even you could check in your baggage, on your own. You could get your boarding pass. You could check in. You could directly go in. All that was there. But for if you had a check-in baggage, you have to go to the check-in counter.
But I think then AI will be really useful in the future, because I find even in Indian, sometimes we are having too much population also. No, we cannot refuse the walk-ins.
Absolutely.
So like when I was in Apollo, there is actually, people still want to come and there is no place to stand, no waiting. You feel so sad because the number of patients are so many.
Imagine. Because that's the power of population. That's
Patient and doctor ratio.
Yes.
Patient versus doctor ratio is too high in India.
And
so the waiting area is...
People have a lot of money. I was reading an article that after COVID, we said that we are at loss, and the country's economy has gone down. Maximum number of high-end cars were sold in India. I had that article. I was reading that article. Across the world, I think India has probably bought maximum number of high-end cars. So we can't say. Only thing is, it's a disproportionate, distribution of economics. So we'll not deviate and we'll not talk about that. The whole idea of design thinking is that if you are able to walk with your patient and see what you expect as a patient, then your patient would expect the same. If you can fulfill that, your patient is going to be happy. If you say their expectation will be further increased, okay, I will upgrade further. After all, patient is paying. Pardon me for saying this. I was reading yesterday, particular hospital organization have 10,000 some beds. They have bought these hospitals, they have bought this hospital. This is all a money game. And we can't say we are in losses. I think healthcare made a lot of money during COVID. I have even read this article.
Apollo versus Manipal is happening 10,700 beds. Apollo at 10,500 beds.
I didn't want to name, you have named, but I was reading the comparison between Manipal and Apollo. That they are, and Max is also, trying to get into the race. So it can't be without money. On one side, we are saying patients are not paying. Then who is paying you to buy these beds? So let's not get into it because we are not there. We are very, at a very basic level. But the whole idea is, if I can, customize services as per my patient's requirement, I can create more satisfaction. Quality. See, that's the reason why medical tourism in India is going to come in a very, very big way. It's already there, I know, but it's going to be in a very, very big way, because there is no any country that can give quality, care and service and patient service that India can give at this cost. It's still very, very cheap for everyone. So as I said, I can see some answers in the, let me read. Yeah. Okay. Yes, Lavanya, web check-in is very old thing of past that we are all doing. I think especially like those of us who are traveling very often, we are very regularly doing web check-in. But with the checked-in bag, I always had to walk to the counter. For example, when I went to Bangalore, it was a 4 days visit. So I had a little bigger bag. I could not take it in the cabin. So I had to check in. But I was very happy to see when I was returning from Bangalore that there's a counter, where you can self-check in your bag. You have to just scan your boarding pass and keep your bag on the conveyor belt. It will weigh, and then it will produce you the receipt that it has received your bag, and the bag would go off. It's manless. It's a manless kind of a thing. So that's the idea, how they are trying to make these services more efficient and better. And that's how see, innovation and improvement has to be endorsed happily. People who are threatened of AI, I think they are still looking at it like when people looked at computers when computers came in almost like 30-40 years ago. Same way, I can see some more answers. AI generated tools can help triage. Yes, of course. So they can spend less time at hospital. Nowadays, patients are also expectations are, oh yes, I agree. And why do we feel bad about it? Be happy. पेशेंट मांगेगा तो उसको सर्विस मिलेगी तो क्वालिटी ऑफ केयर इंप्रूव होगी। कल पेशेंट पे कर रहा है भाई, फ्री नहीं मांग रहा हमसे, ये भी याद रखो। यू आर चार्जिंग, सो यू कांट से कि yes, medical tourism is going to increase in Ayush treatment also. Okay, I didn't know this. That's interesting. I wish we have
completely, not only in Ayush, in yoga also, where they are coming from outside and they are taking a package. Okay. And yes, with yoga, then this Ayush treatment complete, especially the Kerala type treatment is there. So they are coming down from outside, yes, and they are taking, because Ayush treatment you won't get any other country. In India only, we are famous for that.
And that also from an authentic source.
Yes, exactly. So they are asking for a whole package as well. Because I am also, I'm doing that course. I'm about to complete that course. So we studied that even for Ayush also they are coming to India. Previously, all used to come for our neighboring countries, especially like Bangladesh, Nepal, and all. There is treatment is very, you cannot get doctor that much. And nowadays, even doctors are going to do their polyclinic over there. They take doctors, dentists, then any specialization like nephrologists they don't have in Bangladesh.
Very good.
So they take, yes, they take like that way.
Thank you for sharing that. Thank you. So this is how you can actually use design thinking to upgrade your services, to improve your services. And it's not the whole hospital has to work on it. In your own hospital, in your own department, in your own area of work, you can use this concept and improve your services and meet your patients' concept. Although I would say healthcare is slightly slow to respond to these services. As a result, we are still not that quick to implement it. But yes, things are changing. You can see this being used in healthcare also. For example, this is one of the, MRI for pediatric patients. So they have kind of, renovated the complete area, as per the child's requirement or emotional needs. And I'm sure you must have seen these in some of the hospitals. This is the waiting area of one of the hospital again, because now they realize that waiting itself is not a very enjoyable experience. So can we create more comfort to make it enjoyable and relaxing? This is another OPD of another hospital where they have tried to create almost like 5-star kind of a comfort for the patient. It actually doesn't cost much, let me tell you. It doesn't cost much. It's one-time investment, but then the whole ambience relaxes the person, makes the whole experience very, comfortable for patient. So I think now is the time that we not only understand patients' expectations, but we actually meet them midway. That's the journey of understanding patient expectation, and be open to the idea the expectation will change, will vary. When they come in, they want treatment. When the patient is settled, they want comfort. When they are going out, they want discount. So these are all very, regular expectations they will have. Can we work towards it? So to sum up this topic, I think the common expectations of the patients, mostly it is compassionate care, effective treatment, clear communication, respectful treatment, accessible and timely care, respecting their privacy, cost-effective care, and high-quality care. I don't think it's too much that they're asking. Only thing is we'll have to customize it and work towards it. So that brings me to the end of the topic. Any questions? Yes.
Dr. Indu, see, one particular challenge that I face, the certain group of patients, they wish to know all the details. I usually take an informed consent in the context of surgery and post-op care, and especially the sick ones or people with unexpected complications. There is one set of, by and large, patients, once you inform them, they're okay. You communicate, they're okay. There's a small subset where they ask you leading questions. The more you inform, and the more they delve into the smaller detail, especially the patients in the ICU. So the morning you come for rounds, they already know the patient's hemoglobin, they know the count, they know the ABG, and there is a limit to what you can share and what they can decipher and what they can understand. And this one challenge I find is if you tell them the count, and then there'll be a cross question of why is the count high, and then we can, in simple words, we can explain it could be a bacterial infection and things like that. But they keep on giving never-ending, So, and we try to explain based on the emotional status, what they can take. And if you try to say something, they want more. If you didn't say something, if you hold back something, and again they're disappointed. And this is very small subset, but because you are a PhD in psychology, how do I identify? Many times we're able to identify that these are troublesome people, but how do I be prepared, and how do I how can I be able to maybe assess them in a better way? And and many times I feel like a victim in situations where I've done my best and I'm trying to explain every day. I spend a lot of time with the patient's attenders, because personally in my life I lost my dad when I was young, and similar situation where he underwent a major surgery. Nothing was explained to me or my family. And a lot of difficult outside ICU, 10 days we were all there. So from then on, my the way I approach patients completely changed. So more than the patient inside the ICU, I treat the attenders outside. So and this group, and many times I felt like a victim. I felt so disappointed that in spite of all this, I don't sleep. When we have a complication, somebody's sick, we don't sleep, and we think, what all can I do to improve? And in all honesty, we explain, and we feel cornered. So, what is your perspective on this?
I think before I answer, I would want 2-3 people whom I know they would be able to, throw light on it. I want them to answer. Dr. Mehul is handling critical care. So I think I would want him to speak, and then Dr. Priyanka, I think even you have a lot of experience handling. So I request both of you to speak on this one by one. But of course, I'll definitely add my perspective after they have shared their thoughts. Dr. Mehul, please go ahead.
All right. So this will be a perspective from inside the ICU. You are a person for me outside the ICU. You're a visiting person for me. I'm the person who's there 24/7. If I was in your place, I would be giving the charge, and this is what we do in our unit. The visiting doctors give the charge to us. We address the nitty-gritties. Your problem is the nitty-gritties. Your problem is the system. Your problem is the time of communication. Your also problem is ICU is a dynamic process. It's not going to be like a ward where you come in the morning and you come next day morning. My situations in the ICU change minute to minute. So it has a gravity, it has a fluidity. So if you have your system in place, probably these would not occur. When it comes to a situation where you have a person who has a questionnaire or a Dr. Google, you will have to have what we do in our unit is something called as a multidisciplinary video consultation. We make the relative 3 of them are allowed under a video consult, a counselor, the nurse, the primary doctor, or the main doctor, who is the referral doctor, and us sit across, give a dedicated time, have them jot down their problems, and address it there under a video consultation 1:1, including complications, consequences, and financial implications. After that, on a daily basis, the ICU generally communicates with these relatives on a handheld form, a form which is signed by the relatives with only one point of contact. Your problem is that when you get one patient with 10 relatives and you're trying to answer the questions of 10 different relatives. So communication in the ICU needs to be streamlined in a very different manner. And if that happens, I don't see any of my referring doctors spending more than 2 minutes outside the ICU with the patients. That's the way we deal with it.
So,
Thank you, Doctor.
in our scenario, in obstetrics, either the problem is that the mother has had a complication, or if you're doing a surgery, there's a complication. So if it is a postpartum hemorrhage, I've had a patient even with amniotic fluid embolism, we could save her life, but couldn't save her uterus. And the only complaint they had was that she doesn't have sensation in her finger, So that's a patient's expectations will be, you saved her life. And I was told you should have done a cesarean 1 hour before you delay. You did not do cesarean, so she had a problem. So like that, we will keep having a lot of things. So what I do is just always, like Dr. Mehul said, I don't want to keep talking to each person who is, coming. Every time, morning, evening, there'll be so many relatives coming in. So just identify who are the main stakeholders there, the partner, the parents. I actually try to sit down with them and also not in a very rushed way. Have a first, if a critical event has happened, patient is in ICU, sit down with them, tell them, write to them, give them information. This is what it is. Don't do your research or the Google search. Or if you have the questions, write down all the questions and bring it to us, answer them one by one with the ICU in charge. So that is something I also make sure that, we have finished that one conversation. If they want a detail that they have not been explained in the ICU, that's the thing. Another thing is with the NICU also, whenever there is a baby who's admitted, or they will say you didn't anticipate the preterm labor, whatever. So again, sit down so sitting down, talking at one point of time, answering all the questions makes sense, because they will have the questions. And every time if you're a surgeon, you cannot expect when you have the complication. But each time if you beat yourself up, then it's not worth it. So maybe you have your team, have a plan with them, have a lot of written information given to them. And because otherwise, if you give their number or their WhatsApp, that means it will just go on and on and on. It will never get over. So disassociate your emotions of the complication from what has happened, and also be as objective to them and tell them these are the facts. This is the surgery. This could have happened, and we are doing our best. So that's the transparency we can give that. But every day you cannot be, spending 30-40 minutes standing outside the ICU talking to each one of them. Not possible.
Just one point.
Yeah, Dr.
I just tell I think this is something that helps me out a lot. I tell them in a very colloquial way to come to base with them and break ice, because I'm no God.
Yeah.
To give you the treatment. You can even look at the treatment online and come to me if you have questions. My point is to give you treatment. I'm so sorry. I don't know where did the balloon.
This is the expectations. We got delighted.
No, I think it's the AI in the Zoom that makes it like that. Okay. So we tell them that our job is to give the treatment. The response has to come from the patient. If the patient's body is not able to respond for whatever reason, we can alter it, but that's the best we can do. And these would be the complications in case the response doesn't happen. Simple example, somebody coming in shock after a cardiac arrest. I would tell them, the first question is he okay? Then the next question is he going to be awake? Is he going to be fine? Is he going to be obeying? Is he going to live his normal life? There is a halt to all of that. And there's one simple answer. You will get all your answers on the 3rd day onwards. You will have to bear with us for 3 days. And then we will be able to give you updates, but you will have to bear with us and wait. Our point is to do the treatment. When we get the appropriate response or we do not get, we will keep you updated. That's all that we do.
Thank you. I think both of your input is very valuable, and that will give some direction.
And also, sometimes I involve another colleague at my level or somebody senior with me, so that, group practice always helps shoulder. Two heads think better than one. So they also know, okay, you're not going out of the way to cause harm. I tell the patient, nobody see this is something which was totally unanticipated, or even if it's anticipated complication, just that helps.
So just to add to what both Dr. Mehul and Dr. Priyanka has shared with you, couple of things that will help you to be prepared for something like this. So we all do medical triaging, isn't it? We identify patients who are very critically ill and we make sure that we handle them, give them prompt attention. Similarly, we have to learn social triaging. This is the term I would have talked in the next session when I would talk about managing complaints, but I'm talking it here because you brought this up here. It's very important to know and anticipate that kind of a behavior from the patient or patient party when there are such situations. For example, if the patient had suddenly fallen ill, patient was fine and sudden complication or bleeding or some kind of a condition, that is something that was not expected. So family is going to overreact to that situation. Somebody who is VVIP, definitely there'll be more attendants and more people inquiring about that. Similarly, somebody is a bureaucrat or a politician, expect a lot of interference and questioning. So do that social triaging in advance, so that mentally you are ready that this family is going to be little more demanding than others. So mentally you are already ready. I will have to give them more time. So I was talking to my daughter one day who is practicing dentistry in US. I said, how do you manage when patients are very aggressive and they are very, they sometimes, literally lose their control? She said, do you know that we do disc analysis for the patient? So disc analysis is actually a personality test which is done, which is very extensive. I said, how is it possible to do disc analysis? You can't make the patient sit and answer 100 questions and then you do the analysis. She said, no, we don't do that kind of analysis. The first person who attends the patient would write in a coded language that what is the personality type of this person. And they are trained, they are taught about it, but in a very simple way. On what basis do you categorize them? So if you are able to actually identify, okay, this person appears to be, is well read, so he's more likely to ask questions. Or this person is tech savvy, so he's more likely. So something like this, you will be able to read. So that is one thing. So in those situations, be mentally ready to discuss. Second, if they're asking question, I would say be as transparent, as honest as possible. Anything you hide, and if that happens, they will blame you for hiding it. Don't hesitate, don't be blunt, but come out clearly. Yes, this is one of the possibility. And let it be their call whether they want to continue the treatment or they want to discontinue the treatment. The biggest fear we have in telling the truth is that the patient will run away. If you get rid of this fear, if the patient wants to go, more than okay. It's your call. If you want to take, go ahead. But this is what is advised. This is what is the protocol. This is what we are following. Do you want me to speak to any of your doctors whom you know? Do you want me to explain them? I'm open to the second opinion. So when you do all this, they get confidence in what you are doing. And of course, we have to practice evidence-based practice medicine. So there is no doubt about it. I can't do, incomplete work and then be scared, okay, if somebody comes and asks me. Sometimes they say, I have a relative in US, can you talk to that person? And the immediate thing is that comes on our face, why do you want me to talk to that? That's not my job. I will not do that. Make use of that and take advantage of it. Take advantage.
Because by the time all their ICU copies would have circulated all over the world.
Yeah, but when you will talk to that person will become your spokesperson. That person will speak the language that you speak. You already have somebody on your side who will do all the talking for you. And like Dr. Priyanka said and Dr. Mehul said, identify the primary caretaker. I always tell to people who are handling, critical care areas, please identify the primary caretaker. Their name and phone number should be on the case sheet. Make sure that you meet that person twice or thrice in a day. Update them and also tell them, in case if any other relatives want to ask something to me, please ask them to come only during visiting hours. Till then, you handle them. So that way you save your energy, that you don't talk to everybody and anybody who comes to you. And you are also updating, and make sure that you document. Once you have updated them, write down that this is what I have explained to you. I am signing it. I request you to sign. So next time when somebody says, "Hame to bataya nahi tha," you will always have the name and the details of that person. No, there was somebody called Vinod. I think he was there here. You were not here. I know you are his son. You were not there, but there was. Oh yes, I had gone to get medicine. I had asked my cousin to be here.
Like then what I do is I tell the nurse that please tell the whoever is a main primary support person, come see me in my clinic, I'm available, and make them sit down, talk to them. That's always they know fine.
And don't hesitate spending time with them. Yes, very important, sit and talk. When you sit and talk, the conversation becomes more cordial. The other party is also receptive to what you are saying. If you stand and talk, it's tiring for you. It appears you are in hurry. And if there are 10 people, they are overhearing, all the more risky. I mean, they can say something which may have senseless message, but then that can interfere with your communication.
I have learned that from neonatologists. Even if the baby is 26 weeks, 600 grams, they will, whatever high risk, they will make sure everybody sitting down and they have a detailed counseling. That is something really they do so well.
Should do it. And don't hesitate spending extra 10 minutes with that patient. They'll be always thankful to you for giving all the explanations. But you used one word, victim. I want to understand what exactly you mean by that.
Yeah, that's exactly the thing I want to address. I want to be addressed here, because what the rest of the things Dr. Mehul and Dr. Priyanka and Yosul share, all that, we do most of the processes.
You feel harassed? Do you feel harassed then?
Exactly. That is the right word. Yeah,
I can feel that.
So I'm seeing how. Intellectually, I'm able to understand what you're saying, Dr. Rindu and Dr. Priyanka and Dr. Mehul, but I feel harassed. And is there, a body or somebody to support doctors like me? Because I'm a lady surgeon, majority of my colleagues are men, and immediately they just brush it off and say, don't be emotional, don't be this. But it's true that I feel harassed. And in fact, I am the one, compared to the male colleagues, I am the one who takes an informed consent. I am the one who's more compassionate. I spend more time outside the ICU. I make my patients sit down. And so I really want to know how I can empower myself, or how I not become harassed. I mean, this is a very complicated, possible bit, but yeah.
Next session when we have, we don't have time, we will do a role play. You will act like your patients act with you. And I'll take your responsibility. Because assertion is the way to deal with such situations. You are knowledgeable, you are qualified, you are doing your job well. But if you are not able to assert, definitely you will always be on defense. So either you will be unhappy, like you said, you feel bad and harassed and on defense. But I think it's to do with just handling the situation. Don't worry, from session 6 onward, it's all about role plays of difficult situations. Bring in as many situations you want to bring in. We will do role plays around it. I don't want to teach you theory, I want to teach you practical. Go back empowered so that you can handle those situations. So the first thing that we will do in the next session will be, you please be ready with this situation. Just brief everyone what the situation is, and I'll play your role and you play patient's role or attendant's role who are aggressive with you or who are not well behaved. And how do you handle that? We will have a role play around it. Is that okay?
And we have the PPTs from next week.
Yeah, you have. I have two things to say. One is, you are not giving me your feedback for the. I feel very bad about it. I've given you just one responsibility. I mean, I expect that that to be fulfilled. I do my duty with great care. I read, I come back with every time new ideas that will, really enhance your learning experience. But I expect one feedback from all of you so that I get to know, am I doing it right? Do you want me to change? Do you want me to improve? That's the thing I'm expecting from you. And second, please take your presentation seriously. You will not get your certificate from me. I'm telling it very clearly to all of you till you submit and present your pedagogy. I'm last time couple of people didn't do it. 4 of them were from BGS, that Gleneagles Hospital, Bangalore. I gave them the option that when I will do the program for the 20 of them, these 4 people can attend the complete program and do their presentation because they were not very regular when I did the online program. I did not give them certificate. I'm sorry, but for this, I'm very particular. If I'm giving you a certificate, I want to be 100% sure that you all have participated and attended and done your assignment. It's just a small thing. Pick up your topic. If you have any confusion, call me, ask me. I will explain you how you have to present your presentation. It's just 10 minutes, 8 minutes presentation. If you don't do it, you will have to record your presentation and the document, share with the group, and then you can claim your certificate. So session 6 onward, please make sure we have 3 people presenting. Thank you. I know it's 10 past 10. I'm holding you all, for so long. But I hope this discussion opens our mind to the idea of understanding patient's point. That's the whole idea, that we have to be more objective rather than going with a biased mind that patients are troubleshooters and they are always expecting something or the other. Oh, I'm so sorry. I didn't do that. Why did that happen? Okay, I think I'll close the session here. Oh, somebody actually opened the whiteboard. It wasn't me. That's okay. So I'm closing this session here. Thank you so much for participating, and see you next week, next Thursday. But one second. Next Thursday, I'm again traveling to Hyderabad, I think, if I'm not wrong. Yes. I have to deliver a talk in a program. So can we keep it on 22nd if everybody's okay with that? Friday. I'll put the message in the group and I request all of you to respond. Thank you. Thank you so much, everyone. Bye-bye. Good night.